Our immune system has billions of T cells. We could actually engage more or less all of them to be equipped with the BITE modality. So here you see a BITE-equipped T cell attacking a cancer cell. Through the presence of the Biotechnology, the T cell is capable of recognizing the tumor cell as an enemy and then destroying the cancer cell, attacking the next cancer cell, and so on and so forth.
This is an adeno-associated virus vector-mediated liver-directed gene therapy approach to treat severe to moderate severe hemophilia B, which is clotting factor IX deficiency. This uses an AAV5 vector that has had the viral genes replaced with a functional copy of the human factor IX gene that has in turn been enhanced by a naturally occurring point mutation that codes for a hyperactive form of factor IX, so-called Padua factor IX. This boosts the effective activity of factor IX in the blood plasma by 6 to 8-fold. And the vector is delivered as a single IV infusion in the outpatient setting, and within a couple of weeks, factor IX expression is sufficient to protect from bleeding. This study is the first phase 3 study to report findings on their entire cohort of subjects, and it's also the largest cohort of subjects, 54 subjects, who've received gene therapy for hemophilia to report to date. The subjects in the trial have achieved a mean factor IX activity of 37% at 26 weeks following dosing. This is just shy of the non-hemophilia range that starts at 40%. The factor IX levels have remained stable over the course of the study, with the longest follow-up now being 18 months. And these levels have allowed the patients who've achieved transduction to cease prophylaxis for the duration of the follow-up period, and the number of treated bleeds fell by 91% compared to a 6-month lead-in period when all the patients were on prophylactic factor IX infusions. All AAV-mediated liver-directed gene therapy trials to date have excluded patients with pre-existing neutralizing antibodies to the AAV vector, and these appear presumably due to natural exposure to AAV over the course of your lifespan. However, preceding phase 1 and 2 studies for this vector suggested that pre-existing antibodies to this AAV5 vector would not impact transduction. So although the patients in this phase 3 study were tested, they received dosing anyway. And the results show effective transduction in patients who had antibody titers as high as a titer of 678. More than 42% of the subjects had pre-existing neutralizing antibodies, and we observed no correlation with any safety or efficacy parameters. Another important additional safety aspect of this trial is that only 9 subjects showed elevation in liver enzymes following treatment. That's considered a marker of an immune response against the liver in response to the AAV transduction. And if it's not managed appropriately, this can lead to loss of factor IX expression. However, those 9 subjects all received a short course of oral corticosteroids per protocol. They all came off steroids before week 26, and the factor IX levels were maintained within the mild range. Well, this study included subjects as young as 19 years old all the way up to age 75. The mean age was just over 41. It included subjects regardless of HIV status, provided it was well controlled. Half the subjects had a history of hepatitis C that had been fully treated, and many subjects had significant joint pathology before entering the study. So this was really a well-representative group of subjects compared to the broader hemophilia population. Now, because this uses a liver-directed approach, we did have to ensure that subjects had reasonably good liver health to be included. So the big takeaway is, because of the lack of observation of impact of the neutralizing antibodies, this means a much larger population of patients would be deemed eligible for this therapy. Well, these are very encouraging results. It maximizes eligibility for patients by being able to treat in the presence of pre-existing neutralizing antibodies. The results are in a range that allow for cessation of prophylaxis and continued bleed protection. Results appear to be durable through the follow-up period to date. The 26 endpoint was a co-primary endpoint, so the other endpoints are going to be the factor IX activity at 52 weeks, so that's going to assess durability, and then the annualized bleeding rate over the whole 52 weeks post-dosing as another important efficacy parameter. So those endpoints should be reached and analyzed in 2021, and decisions could then be made on potentially a submission for regulatory review.